All right, we'll go ahead and get started today. Welcome, everyone. My name is Dr. Rob Murphy, and I'm the Executive Director of the Havey Institute for Global Health and also the John Fair Professor of Infectious Diseases, and I'm a Professor of Biomedical Engineering here at Northwestern. Thank you for taking the time to join us this afternoon for our latest installment in the Havey Institute's seminar series, which used to be on Fridays, but is now Tuesdays, obviously. The title today of the presentation you can see on the screen here is Access to Quality Injury Care in Low Resource Countries, Previous Research and Future Projects. Please take a moment, if you haven't done this already, to follow us on Facebook and Twitter at #FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure. And for more information, you can visit our website, very simple, globalhealth.northwestern.edu/members. Today, we're really thrilled to have Dr. Justine Davies, medical doctor, join us. Dr. Davies' academic interest is in producing evidence to build systems for improved and equitable access to quality healthcare, particularly for cardiovascular disease or conditions amenable to surgery, including trauma. She is particularly interested in the clinical and socio-economic consequences of providing these platforms of care. Dr. Davies is Professor of Global Health at Birmingham University in the UK, visiting professor at Wits University outside of Johannesburg in South Africa, and the extraordinary professor at Stellenbosch University is one of our key partner institutions, by the way. Her research covers disciplines from epidemiology to qualitative research, health services assessment, predictive modeling, economics, and implementation science. She is privileged to have strong collaborative networks with colleagues in many institutes and institutions to help answer these questions. Dr. Davies, Justine, currently works with partners in Rwanda, Ghana, Sierra Leone, Burkina Faso. I hope you haven't been there lately. Malawi, Pakistan, and South Africa. In all these projects, she works closely with the local institutes and academics in ensuring capacity development, which is, of course, one of the themes of our institute. There's going to be time for questions and answers following the presentation, and we welcome you to please submit your questions through the Q&A function that you see in the bottom right hand of your screen. Don't put it in the chat box. Everyone puts it in the chat box. Put it in the Q&A box. That's the appropriate place. Dr. Hirschhorn is going to be leading the question and answer session. So at this point, Justine Davies, take it over. We're so happy you joined us today, and we thank you very much.
Thank you very much indeed. The pleasure is all mine. I'm delighted to be given the opportunity to present at this meeting. Right, I'm going to try and share my screen. That should be me shared. Please shout.
Yes, that's great. Thank you.
Excellent. That's great. Right. Great. Well, I kind of subtitled this talk A Dubious Tale, as I thought I would interweave some of the work that myself and my colleagues do with a little bit of a history about why we do it, and in doing so, hopefully making it slightly more entertaining. And you may be laughing at some of my own misfortunes as we go through here. I'm a Brit, so it's a particular habit of ours to laugh at our own misfortunes. Anyway, so I was going to start, if I can advance the slides, there we go, with a little bit about my own rather dubious and checkered history. I was actually, I work at Birmingham University now, although I live in Newcastle, which is many miles away from here. I was actually born in Birmingham and studied my medical degree in Dundee University, of all places, in the wilds of Scotland. Seems like a fairly straightforward journey, but as we all know, journeys are very rarely straight. So, as I say, we started our history, well, I started mine in Birmingham many years ago, too many years ago. I studied medicine and forensic medicine and medical law at Dundee University. And then, having got slightly bored of the cold, moved to Australia, where I was an acute care registrar in Perth, in Australia. I then hopped back to Dundee University and did an MD, which in British terms is a PhD or the equivalent rather of a PhD for people who are already practicing clinicians. From there, you're American, so a clinical lecturer is one step below the level of consultant, which in the UK is the highest you can go in medical practice. But I got a bit bored with that. I was a medical cardiologist, and I quit as I realized that I didn't really want to spend my entire life doing that. And I did a zoology degree to put human history, we've been around for the last 200,000 years, into the context of that of the planet, which has been around for the last 4.6 billion years. And that was a really interesting way of gaining some perspective on human health. During that zoology degree, I started writing for the lay press, and actually then worked as a journalist for a number of years, working for the BBC and journal outlets, for example, major British newspapers and some scientific press outlets. And curiously, the combination of medical research, being a practicing clinician and doing journalistic writing was essential ingredients for working at the Lancet Medical Journal, which is now, I'm delighted to say, the best medical journal in the world. And it's nice to see that we have been neck and neck with the New England Journal for many years. And for once, the Lancet is on top of the pile, though how long it will last, we do not know. So I worked at the Lancet for 10 years, appraising papers for their scientific value and worthiness of publication, and also trying to translate some of the research that people did into policy. I segged to set up and be editor-in-chief of Lancet Diabetes and Endocrinology in 2013. And it was all fantastic experience of seeing the world's articles, which many passed through the Lancet and the Lancet D&E's doors. But my passion had always been for global health. So I, in 2017, took a sabbatical and went and worked on an epidemiological study at Wits University, which I'll talk more about. I also took up a position of Professor of Global Health at King's College London at the time, and then eventually came back to Birmingham. So that is a slightly meandering journey to where we are now, but all of it has really informed the work that myself and my partners do and how we do it in injury care. I'll stop talking about me in a moment, but what gets me out of bed is essentially identifying gaps in information that lead to a change in policy to improve health, and doing the research to fill those gaps. We also do a lot of work with policymakers, just returned from Rwanda, working with Ministry of Health there to set up an ambulance communication system, more of which I'll talk about in a minute. And that's the work with policymakers is a two-way street. It's to listen to policymakers' needs around research, and also to keep policymakers informed about evidence that could inform policy. And as Rob's previously alluded to, capacity building with partners in low and middle income countries is a mainstay of the work that myself and my team do. First horse picture. So why injury care? I used to live in Cornwall, and somebody in Cornwall once said to me, "Oh, me lover, if you want to get there, you don't want to start from here." But I think that actually starting a talk on injury care from the back of a horse is a good place to start. So, serendipitously, while setting up the journal, Lancet Diabetes and Endocrinology, the person in the office next to me, her phone was ringing and she was away, and it was ringing rather incessantly, so I picked it up. And it was the Royal College of Surgeons, and they wanted somebody from the Lancet to go and talk to them about the Lancet's interest in global surgery. And so I said, all right, I'll come along and give a talk. And so I did. And many of you are probably familiar with the siloed approach by which we conduct our research and development work. And that was writ large, really, at this Global Surgery Frontiers conference, where there were multiple people getting up and presenting the fantastic work that they were doing. And there was a lot of overlap in that work, and there wasn't really a joined up approach. So I was sitting next to these two reprobates, Andy Leather and Lars Hagender, and getting slightly frustrated about this siloed approach, and kind of turned to them and said, what we need actually here is a Lancet Commission on Global Surgery, really to unite the forces behind surgery. And Lars and Andy said, we've been thinking the same thing. And I went, well, that's quite great, because I'm an editor at the Lancet, and let's see what we can do. And so we teamed up with this bunch here. I'm sure some of whom you recognize. That's me looking younger with short hair. And Paul Farmer, obviously, John Mira from Harvard, Russ Gruen, who is now Dean of National Australian University, I believe, and a gentleman who leads the surgical program in Mongolia. And we worked for 2 years on the Lancet Commission of Global Surgery, which basically identified not just the issues with providing surgical care at healthcare facilities. It took a rather broader approach and looked at the whole surgical patient journey. And so really started framing my thinking on health systems rather than healthcare services at facilities. At the same time, second horse picture, I ended up with this fellow, and it should have been a warning to me that his nickname was Psycho Killer Pony, but I bought him nonetheless. His name is Santa. I still have him, and the other one. But Psycho Killer Pony resulted in many of my bones being broken. As I fell off him trying to control him. I can't ride him, somebody else now does. And as a result of those bones being broken, I decided to take a sabbatical and do a bit of thinking, and took time off at Wits University, who have a rural campus, which not unpleasingly is right next to the Kruger National Park. So myself and my husband moved there for a year, and became members of a epidemiology study called Havey, which actually looks at, it's a longitudinal survey of aging of people in South Africa, and in South Africa, I digress slightly, because the life expectancy is lower than we would consider in high-income countries, people over 40 years of age are enrolled in this study. What's really interesting, though, about the study site itself is that it's a health and demographic survey site. It has been collecting data on the population, and that's about 120,000 people for the last 21 years. And at its most basic, it's a yearly population census with verbal autopsies done on people who die. Now, the reason for doing verbal autopsies is that in South Africa, even though there is death registration, that's not entirely accurate. And the verbal autopsies are a really useful way when there is not accurate registration data of estimating the cause of death. It also has a module which is called COMCATS, which is about the circumstances of mortality, where data are collected that try to ascertain what the stages in the patient's healthcare journey that led to death are that most contributed to that person's death. Essentially, it uses now we've added 4 delays model, looking at delays of seeking care, delay 1, which is from the point of the incident, I'm interested in injuries, happening to taking the decision to try to get to care. And then delay 2 is from that point to reaching, we call it definitive care. Other people use different stages of care access. Delay 3 is from reaching definitive care to receiving quality care. And the delay 4 that we've added is from discharge from the acute care episode to being rehabilitated to optimal function. So with this time to think and having multiple broken bones as a result of psycho-killer pony, we decided to use this data to look at delays to care using a 3 delays module for people who had been injured. The good thing about verbal autopsy data is it's quite detailed. So we were able to capture information that enabled us to ascertain the percentage of deaths that were actually avoidable deaths from injuries. An expert review helped us with that. And we found the headline was that 40% of deaths, all injury deaths in this area of South Africa were actually avoidable. And 40% of these actually occurred pre-hospital. And I know that leaves 60% that actually occurred in the hospital, but 40% of injury deaths that are avoidable occurring pre-hospital is also noteworthy. We did the same for all time critical conditions this time, so more emergency conditions. And I won't go into the definition of time critical conditions here. It's been reported in the paper that you see here and also by others. What I will draw your attention to, although you can't see the detail, is this graph here. The inner ring is the first healthcare seeking act. The outer ring is where the patients were in their healthcare journey on the day that they died, or the middle ring rather. The outer ring is where they died. The grey chunk here is the most common pathway, and that was actually that people didn't seek healthcare at all and died outside a healthcare facility. So similar to what we found for injuries for time critical conditions. I know there's been a lot of work on quality of care at healthcare facilities, and this doesn't detract from that work, but it also suggests that we should not neglect the 40-odd% of people that actually don't get to healthcare for various reasons and die because of it. So that meant a real focus then on a health service approach to injuries in the work that we do. So I had and still have a fantastic PhD student. He's now my postdoc student, John Whitaker, who started to look into this in more detail. And essentially, he looked at the state of evidence around delays to access to care, and he did a systematic review of all evidence that looked at health systems, no matter what sort of health system lens they took. So you can see here from the Prisma diagram that he sifted through an awful lot of papers, identified 16,000 papers, and eventually whittled them down to 111 that met his inclusion criteria. These are the countries in which studies were done. I'll draw your attention to B here, where you can see that actually there are only a smattering of studies that have looked at any health system approach to dealing with injuries in lower and middle income countries. But I guess that what is both shocking, and then when one thinks about it, probably not that surprising, is that most of them are focused on delay 3, which you might remember is at the facility. So delays in seeking or getting quality care once one has arrived at the health facility that can provide them with care. So that's where most studies have focused. Fewer on delay 2, that's actually reaching care, and even fewer on delay 1, that is seeking care. This bit in the middle, 3 papers. Now, this was published in 2020. Only 3 papers had actually taken a whole health system approach, which I found worrying. So I decided that that's where we should focus our approach. So one of the things we did in Rwanda was actually gather multiple stakeholders together to ask them about where they thought delays in accessing care were. So we did a workshop with policymakers, patients, people involved in providing care at the scene, ambulance drivers, police, and healthcare workers. We supplemented that with a literature review to try and map where the barriers to access to trauma care were in just Rwanda. These were all of the barriers that we found, and I won't go into much detail here, apart from the middle column here, the adequacy and utility of the existing evidence. We also asked people to comment on whether they thought there were enough, or there was enough evidence to address the barriers. And for most of them, they reported that there wasn't actually enough evidence to address the barriers, which told us that we were on the right lines doing what we were doing. So what we did with all of these barriers that we collected, we mapped them to the delays, as you can see in the center here. And we also mapped them by categories, individual factors, societal and contextual factors, financial factors, etc., etc. And I don't expect you to interpret this at all. My postdoc student was kind of driven crazy by this. But essentially, it shows that each individual delay is associated with potential, or individual barrier, I should say, is associated with potentially multiple delays and also multiple different factors, overarching factors. This is why health systems are wicked problems. They're very difficult to solve as you've got multiple interacting factors there. You change one, you change multiple others. But it's also potentially a reason for optimism, as you might find 1 or 2 of these that you can address that actually solves a lot of other problems as well. So with this whole health systems approach in mind, recognition that there isn't a lot of evidence to inform action, we got funding for a 1-year development project from the UK government. That was called Equitrauma, and it was equitable access to quality trauma systems. And we did this study in 3 countries, Rwanda, Ghana, and South Africa. We used 4 methods to try and triangulate about the barriers that people experienced. We did surveys on experiential quality of care, focus group discussions, interviews, a governance survey to try and look at the country governance structures for injury care, and then we did multiple stakeholder workshops. We used a mixed methods approach, which was particularly stressful for somebody like me who is highly quantitative, but it worked. We combined the barriers in delays to access to quality care using a 4 delays framework. And for quality, and I'll get more onto this in a minute, we use the Institute of Medicine's quality domains framework, which has 6 domains of quality. As I'll speak to those in a moment. What we found, similar to John's paper and our work in South Africa, which that actually delay 3, receiving quality care, was probably the most prominent, with delay 1 and 2 being equal, and delay 4, which is rehabilitation, being the least prominent cause of delay. But what was of interest to us is the number of barriers that we found using this mixed methods approach, which was 121 barriers in total across all of the countries. We also found it interesting that only 31 of those were actually shared between countries. Most funders like to hear that research is going to be applicable between one country and another, one context and another. And I think what this work signaled to us is that that is not always the case. Apologies, somebody's trying to call me. I have switched off WhatsApp. We then took a seg into looking at provider competency, given that we were finding that quite a number of the barriers reported were in access to quality care at the facility. We developed a tool to assess provider competency. Much evidence before now has been about people's reports of provider competency without an actual tool to empirically assess provider competency. So again, my PhD student, John Whittaker, developed a tool to assess this. And he, to do this, used 4 scenarios from primary trauma care principles and advanced trauma life support guidelines. Essentially, clinicians and providers of clinical care were presented with scenarios and asked to describe to an assessor what they would do if presented with such a patient. Obviously, in trauma care, you can't really do this on real life patients unless you spend a long time observing people. So the assessor then ticked off what people did against a list of what people were supposed to do based on these guidelines. The 4 scenarios were blunt chest injury with a tension pneumothorax, penetrating abdominal trauma, severe head injury, and isolated lower limb fracture. And I just wanted to draw your attention to this, which is the scenario about tension pneumothorax. John asked about what people would do in their current situation and what they would like to do given proper resources. Now, the scenario of tension pneumothorax is a little bit concerning. I'm being English, a little bit concerning means very concerning, in that not everybody would give oxygen, even, as you can see in orange here, if oxygen were available. So clearly some of the lack of giving oxygen is due to its unavailability. But that's only 85% of providers would give oxygen is troubling. And the other thing that is highly troubling, given that the scenario clearly suggested tension pneumothorax, was that very few people would feel for the cardinal sign of tension pneumothorax, which is tracheal deviation. So this kind of validated the findings from other studies that quality of care provided at facilities is a real issue. Doing a whistle-stop tour, we've done a lot of research in the last few years, and taking a brief seg into geographic informations too, systems too, because although we've spoken about quality of care provided at the facility, it's impossible to get quality of care at a facility unless you can actually get to the facility, any facility. And many people since this work and during this work going on have looked at geographical information systems. There was a report published in Lancet Global Health in around 2019, which suggested that I think 94% of people in sub-Saharan Africa can get to emergency care within 2 hours. And so that triggered this research done in northern Malawi, because it's unbelievable. And I think even the authors of the original paper, Paul Uma et al., didn't believe it. And the issue is the systems that we use to assess whether people can get to care are often highly modelled and based on ideal road speeds from Google Maps. What we found in this is even using that highly modelled data, only 20% of people could get to a government secondary facility within 2 hours. And no person at all in this area in northern Malawi, which was a large area in northern Malawi, which is a rural area with a high prevalence of injuries, no one could get to a secondary care facility, despite the quality of care there, within the so-called golden hour for trauma. So the recommendation is people with moderate to severe injuries should get to trauma care within 1 hour after an injury occurring. Nobody in Malawi could do that. Interestingly, what you might be able to see from this graph here is that this is the GIS time travel estimate here on the x-axis, and on the y-axis is the patient-reported travel time. This line, dotted line here, is equivalence, and patient-reported travel time to centres is consistently higher than GIS travel time. Now, at the time of doing the study, not very many people had looked at this. Since then, this work has been validated in many different settings. So suggesting that the GIS information that we've previously used to say that access isn't so much of a problem in itself is flawed. So I was just going to talk to a few slides which talk about our ongoing work. We started this program of work in 2017 and have done a lot of work since then on whole health systems for access to quality injury care. And we've still got a lot of work to do. So we've won 2 large awards from the UK government to further this work. And the first one is called Equi-Injury, building on equi-trauma, where, an original title, but essentially we're expanding our equi-trauma work to another country, which is Pakistan, and actually increasing the number of methods that we're using. It's funded, as I say, by the UK government, and my partner in crime is Kat Chu, who is a professor of global surgery at Stellenbosch University. For this, we are using a 4 delays framework, a WHO health system building blocks framework to look at care provided at facilities, and the Institute of Medicine quality outcomes framework that I alluded to earlier, which classifies quality outcomes as being effective, safe, patient-centered, equitable, timely, and the sixth one is efficient, which we're not including in our study, as efficiency in the context of the quality outcomes framework is about lack of waste, which is important, but we felt less relevant to our study. We've just started, and over the next 5 years, we will be delivering these work packages. Work package 2 is a massive data collection effort in each of the countries to track the patient prospectively from reaching a hospital and retrospectively in their journey to reach the hospital, to collect data on barriers and time delays. We'll be using that data to develop an injury pathway model, which essentially some clever people from the University of York will be developing, which we hope will show visually as well as mathematically policymakers where they should invest or could invest to improve lives for the least amount of cost. So that work is ongoing. Alongside it, and this is what interests me, is to try and get the work outside of medical papers. We're forming stakeholder groups of patients, healthcare workers, community members, and policymakers to ask whether they want to work together to improve policy for injured people, and if so, how. So that's an ongoing stream of work, which we hope, if it's successful, will lead to our research being more embedded in policy and also go beyond our research and be informative for other research and policy development also. The other study, which is why I've been in Rwanda for the last 2 months, is called Rwanda 912. And this is I think, a fascinating project because it's terribly, terribly difficult. And that's where I like to spend my time. It's again funded by the UK government, and it's a partnership between the Ministry of Health, a software developer, and academia to develop and test a novel ambulance communication system in Rwanda. This hasn't been done in any low resource setting before. So we're kind of in the dark a little bit. And we have multiple different areas of expertise contributing to the project, which is led by myself and my colleague, Jean-Claude Biringiro at the University of Rwanda. And these are the expertise areas that we have involved, and getting us all to share a common language is challenging. Why are we doing this? Well, this is the mess of current ambulance dispatch, which involves multiple calls to try and find the patient, and once the patient is found, to try and find a facility that will take them. In the study, we're going to try to change that mess into this beautiful diagram, which is a more efficient system, where much of the data are ambitiously going to be collected electronically and use a decision algorithm to try to match the patient to the best facility for that patient. The first component of this research is funded by the US NIH. Myself and Sudha Jayaraman and other partners at Ministry of Health have that, and that's developing software to better find the patient. And then once we've found the patient, we move on to this UK government funded study to find the facility. So that's the joy of the next 5 years. for me and partners in Rwanda and around the world. So I will close with a slide. You've heard what wakes me up and what gets me to sleep at night is exhaustion and satisfaction, I hope, from delivering research that really does fill policy gaps. So I hope that was entertaining and you didn't laugh too much about me falling off various different horses and breaking bones. And I'm here to take any questions if there are any, or receive any rotten tomatoes if you want to throw them my way. Thanks very much.
Great. Thanks so much, Justine, for that. And I like the idea that you're both a consumer as well as a provider of the of trauma care. So,
very much so.
Yeah. So I before I sort of dive in, I just wanted to see if there were any questions from any of our folks in the audience. I'm not seeing anything in the Q&A, but please do put something in there. I guess I'm going to then start, which is, you know, what advice do you give the people who are in attendance here? Because you do come at this from a different kind of dissemination, you know, sort of practice into policy. A lot of us think about research into practice, and you're really sort of research and practice into policy. What advice do you give people about how to learn how to do that and how to do it more effectively than we are, besides publishing in a manuscript in a journal?
Yes, experiential learning is probably not what you want to hear, but that's how I think it's really difficult, because I think the field of understanding how to do that effectively is actually quite young. So we are flying blind a little bit when we consider how to do that. Interestingly, working at the Lancet, the ethos of the Lancet was that research shouldn't sit on a shelf. And so that afforded an opportunity for us as editors to work with policymakers to try and put research into practice and then policy. So that provided experiential learning, which was really useful. I think from my experience, what I've learned is that policymakers like a conversation rather than what we tend to do as researchers is kind of go to people and go, here you go, here's our evidence, this is what you need to do. And without actually sitting down, building relationships with people and trying to understand the context from their point of view as well as our point of view. And I think that takes a lot longer than our research funding cycles will allow, but building those long-term relationships is what allows us to work effectively with policymakers. We might not always want to do what they say that they want to hear, but I think it's important to understand their perspective as well as ours.
Great, and that's somewhat related to the question from Ariel. Thanks so much for posting. Academic work is driven by grants, which can be difficult for work in LMICs and more qualitative and psychosocial spaces. How have you stayed true to your interests and what you feel is truly needed by communities while also securing funding?
Oh, Ariel, nice to hear from you. Yeah, it's not been easy, I think, but yes, I mean, I've told you about 2 large successful grant applications that I have had funded, and that sounds great, doesn't it? But the numbers that have been rejected are a source of huge depression. So I think that staying true to one's interests, if you really believe that you are doing something valuable, then keep going and look for alternative funding sources if the first one, second one, third one doesn't work. I mean, eventually one has to read the writing on the wall if it doesn't work anywhere. But I think try and try again is what I would say. Also, I don't know what it's like in the US, but usually universities have ways of offering seed funding for people, and you can get a lot done with seed funding that will lead to other projects growing from that. So, so I would say perseverance and finding a funding source that actually is really interested in learning about what communities want. We're very, very privileged in the UK in global health to have the NIHR, which has a remit to do research which is not informed by what researchers in high-income countries think is useful, but it is informed by what communities in low middle-income countries think is useful. And I think that's a really valuable funding source. So the other thing you can do, Ariel, is team up with somebody in the UK who has access to that funding. So building partnerships will also allow you to access multiple different funding sources. Hope that helps.
Thanks. Other questions? Otherwise, I, as always, have many, but I want to make sure that other people have a chance.
I mean, one thing, if I could ask, we have a Center for Global Surgery, and one of the, he's not on board yet, but one of the surgeons that's going to get involved is a trauma surgeon. There's also a neurosurgeon who spent a year in Peru setting up a head injury surveillance system. How do you, when you have that, you've got some expertise, what really is the next step? We have seed funding opportunities. What would you suggest on kind of a concrete level with that kind of resources available?
I mean, so yeah, it's so firstly, I mean, neurosurgery registry data is absolutely needed. Neurotrauma registry data is absolutely needed. So I mean, I guess one can look at funding to expand that. And what we're doing in Rwanda, as which I didn't mention, is working on the trauma registry. We're doing it in EMRO countries as well, with WHO. So there's expanding it, there's improving quality of it, there's using it for quality of care improvement, which, as you've seen, the third delay is an issue. Quality of care improvement is absolutely necessary. But also from a policy point of view, and the WHO trauma team are really interested in metrics. So there is potential, I would say, there for talking to WHO about integrating metrics into the trauma registries, which they've developed and are active in many countries, and partnering up with other neurosurgeons with similar interests elsewhere. So we're meeting with the UK government-funded neurosurgical trauma unit next week to talk about their work too. So huge opportunities, I would say.
One of the, and this sort of is possibly a little bit related to this, is trauma is sort of like a big bucket in the same way that, when we talk about quality. And how much do you think it's going to be different depending on the type of trauma that you're thinking about, lower extremity injury from, for example, riding the bodas when you're not supposed to, versus, something that's more complex. How have you started to, or are you planning to start to bucket in terms of the different types of injuries and how that might affect what the possible solutions are?
Yeah, so I mean, it's very heterogeneous, as you say, and different types of injuries also affects outcomes and will affect whether delays are important or not. So yeah, absolutely. One needs to bucket somewhat, but the general principles are the same. So the general principles of accessing care, whether you can get care in the time needed to deal with your injury, whether that care is of high quality, which is determined by WHO building blocks as well. So the principles are the same, even if the treatment for individual traumas may be different. So if you have neurotrauma or a compound fracture, then you still need access to an OR, you still need an anaesthetic, you still need access to pain relief. So quite a lot of the principles are the same. So thus far, we tend to try to avoid siloing and bucketing.
Got it. We have one last question. This is from Doyen, another person you've met. What's the main barrier, infrastructural or otherwise, across LMICs causing delays to injury care? And for solutions, therefore, what do you think needs to focus on? So a small but simple question.
Thanks, Doyen. I knew I could count on you. What's the main barrier that actually comes up all the time is cost. Absolutely, all the time. Cost of accessing care, cost concerns limiting seeking care, and cost of providing quality care at hospitals. A massive underinvestment in trauma care throughout the patient journey. So what are the solutions? Well, I guess this is one of the reasons we're doing our injury pathway model, is to try and look at where to invest, where is best to invest for saving most lives and preventing most disability. So we can get an idea, because you can't, you know, resources are limited. Health economics is about providing care in conditions of scarcity. So, you know, you've got limited resources. Where should you put that? Those resources? And at the moment, to be completely frank, we do not know. So hopefully in 4 years' time, we'll have an answer for that question. And
Rob, do I have time for one more, or do you need the
Yeah,
time?
go ahead. One quick one. We have 5 minutes.
Okay, excellent. So I appreciate how you have stressed the importance of integrating into existing Ministry of Health policies, service packages, HMIS indicators, etc. Do you have any recommendations, or I say even advice, for clinicians and researchers who wish to offer recommendations that are forward-thinking but thoughtful of the speed of these policies expanding? So how do you push things forward while being respectful and integrating into what's already there?
Yeah, so I presume your comment, Ariel, there about speed, it means it is alluding to the fact that often these policies actually go very slowly, because they do, even if there is the even if there is the perception that everything is running at rocket speed, actually policy change is really slow. And my problem is that I run at rocket speed. And so trying to encourage and partner with people, I think, is the best way to do it. We often have a sentiment of trying to tell people what to do. We've got the research evidence. We know we're in the possession of knowledge. Knowledge is power. So we use that power to say, hey, you need to solve this. You need to do this. Whereas actually, sitting down and day-to-day working with people and spending time, like I've just spent the last 2 months in Rwanda, has been really valuable to being able to come to a mutual and shared understanding of what the issues are and how to address them at the speed that the policy development in each country will allow. So Rwanda has aspirations to go fast, but on sitting down, you realize that it actually goes quite slowly and you can only push so much. I hope that kind of helps. I think understanding the context and being respectful to people's timelines is essential.
Well, great.
Always a little bit challenging when you're talking about trauma, I would assume. So thank you so much. Rob, back over to you.
No, thank you, Justine, for taking the time to share all your insights and experience. I certainly learned a lot. I didn't realize there were quite that many barriers, but it's a learning experience. I want to thank everyone in the audience for joining us and submitting the questions, and it was a good discussion. We invite you to join us next month for a presentation from Hong Zhang, who's an assistant professor in medicine at Harvard Med School and associate epidemiology at Channing Division of Network Medicine and Department of Preventive Medicine at Brigham and Women's, or isn't that Mass General Brigham now? I think they changed the name, right?
All
And
depends.
assistant professor in the Department of Medicine and of the Department of Nutrition at the Harvard School of Public Health. Again, thank you for joining us today. Thank you, Justine, for joining us. We really appreciate it. We look forward to hearing more from you. And for those that have registered, a recording of the webinar will be shared via email. And this concludes today's webinar right on time. Thank you very much.
Thanks all.